Welcome to another episode of Progress, Potential, and Possibilities, discussions with fascinating people designing a better tomorrow for all of us. I'm your host, Ira Pastor.
Welcome, everybody, again to another episode of our show, bringing you another really fascinating guest today involved in creating a better tomorrow. Today, we have the honor of being joined by Dr. Peter Fleischut, who is Group Senior Vice President and Chief Information and Transformation Officer at NewYork-Presbyterian, where he oversees their strategic vision and management of everything, including enterprise information technology to lab operations, pharmacy operations, innovation, data analytics, artificial intelligence, telemedicine, and cybersecurity, a major portfolio. Dr. Fleischut's led the development of their organization's award-winning digital health services and the implementation of their clinical operations at NewYork-Presbyterian, David H. Cook Center, a world-class ambulatory care center, and in his previous role as Senior Vice President and Chief Transformation Officer, he focused on creating a single electronic medical record system across the New York Presbyterian system and its affiliated medical schools, including Weill, Cornell Medical, and Columbia. Dr. Fleischut also led their efforts to standardize across New York Presbyterian's 10 hospitals and hundreds of clinics and doctor practices, and oversaw various aspects of their graduate medical education programs in the enterprise. He joined New York Presbyterian, Weill Cornell back in 2006, previously served as medical director in operating rooms, deputy quality patient safety officer, founding director of their Center for Perioperative Outcomes, vice chairman, chief medical information officer, chief innovation officer, and chief medical operating officer. He became vice chair of the Department of Anesthesiology at the Weill Cornell Medical College, where he still is assistant professor of anesthesiology. He's a graduate from here in Philly of Jefferson Medical College. He also attended Wharton at University of Pennsylvania and has received numerous awards and honors over the years. We're honored to have him with us today. A lot of really interesting topics to get into today on the innovation front. But Dr. Peter Fleischut, thank you so much for taking the time out of your schedule.
Thank you for inviting me. I appreciate it. It's a pleasure to be able to join you today.
Great having you. I've been reading all about you, Peter. You've been on quite a journey the last couple of decades, obviously starting out here in Philly at Jefferson and Wharton. Talk a little bit about your background, a little bit about how you got into medicine, anesthesiology, obviously your interest in sort of the business side of medicine. And then it was interesting at the same time, I was reading about you. I noticed even back in medical school, you were publishing on all sorts of interesting health policy issues, from antibiotic stewardship to technology transfer practices. Bring us all together, because it's really an amazing background.
All right, thank you very much. Well, first, I was born in Pennsylvania, raised in Delaware. My father was a DuPont executive, and my mom was actually a nurse. So definitely from the Philadelphia area. Always knew that I wanted to go to medical school. Had a lot of doctors in my family, and exposed a lot to taking care of people. And frankly, I wanted to follow in their footsteps, but always was very interested in medicine and business and the convergence of the two. So after college, I spent 2 years learning, researching, taking a lot of classes on how to bring the two together. And probably one of the biggest points of my career was the opportunity to go to Jefferson and work with David Nash. Working with David was transformative. He exposed me to a lot of opportunities, both working on electronic medical record systems, but a lot of database research around population health and exposed me to so many facets of medicine early on in my career. And David's involvement in my trajectory was pivotal for the next 20 years and everything I did since that point. I worked on a lot of different areas in quality and safety while also going to medical school. Had the opportunity to take business classes at the same time. It was a little chaotic. I'd go to med school during the day and I'd get on the bus and I'd take business classes at night. And so that was a challenge. And I had the also opportunity of meeting my wife at the time in Philadelphia, which was unbelievable. At that point, I was really trying to figure out how to put this all together. What was the right specialty? What was the right career path? It wasn't easy trying to figure that out. And ironically, I wanted to be working in an ICU. And I felt that there's two ways to do that. I could be going through and get trained via medicine or become an anesthesiologist. And at that point, I decided, the anesthesiology would be the best career for me. And it was unbelievable. I had a great opportunity to do my residency at Weill Cornell, NewYork-Presbyterian. And so my wife and I at the time, we moved to New York City and basically started my career there and trained as an anesthesiologist. It was important at that point to be in an opportunity really to kind of change. And at the time, I was very, very focused on quality. And it was a lot about culture and it was a lot about communication. Mm-hmm. And a colleague of mine and then another mentor, we put together a concept. At the time, it was very simple. It was called a house staff quality council. And the whole point at that point in our careers was how do you engage the frontline house staff directly with the administration of the hospital and have bi-directional communication to improve the quality of care? It was a very simple concept, but it was transformative. It opened up communication pathways. It opened up opportunities to really be able to move on various initiatives. That concept, we received a lot of recognition and a lot of awards, but most importantly, I think it was replicated at maybe 50 to 80 hospital systems throughout the country. And a lot of hospital systems to this day still have a house staff quality council as a part of their structure. And I think that through all my different experiences till now, I found people are the most important. And the more we invest in people, the more we communicate, the more we can improve the quality of care for patients, no matter if it's pharmacy or lab or IT. And so it really comes down to people and culture. And I learned that early on in my career, and that still remains true till today.
Mm-hmm. Yeah, I enjoyed, listening and reading about you prior to the show, and you talking about this theme of people-centric technologies, and you point out in one interview that you gave that a lot of this, and you progressed obviously. You're practicing anesthesiology, but you're also slowly taking on these other roles in the system, which happens to be one of the largest hospital systems in the world. Chief Innovation Officer role, then information role, then obviously the current role. And you make a point in one of your previous interviews about, this is more than just, what it used to be in the past, where we've got analog stuff and we're making it digital and we're going to make some back office functions efficient. You said, no, this is much more than that. Is the entire process into the patient experience, hence this people-centric approach that you talk a lot about. Talk about, especially for those that are not from the United States, maybe listening to the show, talk about New York-Presbyterian in general. It is a pretty big system. Talk about what your current role means and a little bit about this theme of people-centric processes and technologies that you're so passionate about.
Sure. So New York-Presbyterian, we've been around for almost 250 years, and it's 11 hospitals, and we work inextricably close with our partners at Weill, Cornell, and Columbia. Weill, Cornell, and Columbia, two Ivy League medical schools, both employ the doctors and physicians, as well as we also have some physicians employed by NYP as well. NYP is about a 40,000 person organization with approximately 10,000 doctors as well. And we provide care, tertiary and quaternary care to various communities, upper, lower, middle Manhattan, Queens, Brooklyn, Hudson Valley, and provide unbelievable care to those areas. Primarily, it's about a third Medicare, a third Medicaid, and a third commercial insurance. And really kudos first to our doctors, which I think are the superstars that really take care of the patients every day. They do an unbelievable job taking care of the communities that we serve. In my current role, as you mentioned, I oversee our technology, pharmacy, lab operations. And one of the pivotal parts of that was really converging. We used to have 9 electronic records, and we basically moved all of our systems into one electronic record system. And that was epic. And that was a big change for us. That was a big change. And it was, yes, we needed to get the technology right, but we needed to have the people and the processes right. We at the time had 5 formularies. Those are the catalogs of all the different drugs we use, and we had to go to one. We had 10,000 order sets, and we needed to go to 1,000 order sets across all the hospitals. We had to get 51 different leadership groups, the neurosurgeons, the cardiologists, the gastrointestinal specialists, the pediatricians, the you name it specialists, everybody to come together and say, how are we going to practice care together across all these hospitals, so that we could have one instance and really do this in a standardized way. That wasn't about technology. It was all about people and culture, and really bringing together those structures to do what we needed to do. But now, as we move forward, and people use many words, innovation, digital transformation, we need to embrace the technology that's coming on today, like generative AI and other forms of AI. But it's not about the technology. The technology works. It works in every industry. What the challenge is the adoption. And being a physician-led organization, we need to be able to put forth ways so that the technology can get adopted. And if it does, then it can really improve efficiency, access, and overall reducing the burden of disease.
And, again, per your, taking on this global sort of transformation officer role, the last couple of years have been extremely busy for you. And I guess we'll talk about AI in a little bit, but just some of the different sort of remote monitoring / I'll put in a general basket of telehealth, but involving everything from telemedicine in the emergency care setting, where, not just that you've brought technology into that setting, but also developed these mobile stroke treatment units, interesting telepharmacy stuff in terms of monitoring people after solid organ transplantation. You got a whole telepsychiatry business. Walk us through all things tele, because, obviously we think of NewYork-Presbyterian as these giant hospitals and campuses and stuff, but you're really much more than that. And sort of these telehealth dynamics have really altered the way a lot of aspects of medicine are practiced.
Sure. So around 2015, 2016, we deeply wanted to invest, thanks to the support of the board, our CEO, Stephen Corwin, and also many that had really supported from philanthropy, especially Rita and Gus Hauser, in terms of investing in telemedicine. We wanted to have a very comprehensive program. And remind you, this was all way before COVID. We had everything from, as you mentioned, the ability to do urgent care on your phone, but also to use video in the EDs so that we could enhance and accelerate the time to see a provider. Both urgent care, primary care, but also specialty care, how to enable all of our different 10,000 specialists to be able to get specialty visits, both synchronously over video, but also asynchronously throughout the country and throughout the world, so that we could provide second opinions. We also worked on launching of a remote patient monitoring program, which has evolved over the years, which has now become hyper-focused on heart failure and how we monitor heart failure patients. And then things like you just mentioned, the mobile stroke unit. So situations where a patient could call 911, we deploy the ambulance, and in that ambulance has a CAT scan. And you CAT scan the patient in the ambulance so that you could be able to get the patient the treatment faster. So if there was a clot, reducing the blood flow to the brain, you'd be able to get the medicine to the patient in the actual ambulance and be able to improve brain cells, improve the outcome of that patient. As I mentioned, all this was circa before COVID, and we really pushed to getting to almost 500,000 visits a year prior to COVID. But obviously, as we prepared and we moved into 2020, and the regulations changed, the reimbursement changed, and everything with COVID, it drastically accelerated. So we went from about 500,000 visits to, I think in 2020, we went to 1.3 million visits during the course of that year. And today, that has since reduced, and we've gone to about 20% of our visits via telemedicine, and that's reduced over time. But it's still a core part of something we want to provide to our patients.
Excellent. And as we develop these tools to again, from this patient-centric perspective, you mentioned AI just before, and this has clearly been an extremely hot topic that we see on all fronts, whether it's in using AI and new methodologies to discover drugs, to applications in agriculture and energy production. You have a lot going on on the artificial intelligence front, and we're probably going to do a series of episodes following ours, talking to some of these different thought leaders in the New York-Presbyterian system, everything from monitoring or predicting postpartum depression, brain deterioration in the NICU, and so forth. Talk about your perspective as you've been on the front developing these digital tools. You obviously seen AI come on the scene. Talk about what you've seen as its evolution, about how it is areas that you're excited in terms of how it supports your clinicians, your pharmacists, the nursing staff, and so forth. And if you could just say a few words about maybe a couple of these different projects, and we'll do follow episodes specifically on them. But please.
Sure, no, definitely. First, I think what's our framework on AI is important. There's three major areas that we're interested in running various projects. We have over 120 projects in three major areas. One is improving efficiencies. There's no doubt that healthcare needs to be more efficient. There's many reasons that we need to do this so that we can improve and be able to see more patients. Second of all is access. We need to improve the access to healthcare. I don't think anyone has this perfectly right. And the more we can improve access, the more patients we can be able to take care of and overall improve society. The third is reducing the burden of disease. And this is an area where I think it will take us more time. We need to have the right data architecture. Frankly, we've got to have multi-dimensional data, multi-domain data, like EHR data, pathology data, imaging data, waveform data. And if we invest and have that right architecture, that can really enable us to accelerate our providers that have spent their career specializing in how do you use data to overall reduce the burden of disease. You mentioned a couple examples of them. One great example is Dr. Pierre Elias. He and his colleagues are running two of the world's first clinical trials in AI models in cardiology. And being able to run an algorithm so that you could be able to identify patients that were at high risk for structural heart disease. Mm-hmm. The normal patient flow is the patient comes and sees a primary care doc. They may be getting a medication for high blood pressure, and years may go by. They may see a cardiologist. They may get an EKG, which is the very inexpensive test. And over time, they may become symptomatic from whatever is going on, and then get an ultrasound of their heart, which may diagnose whatever the condition is. Well, what Pierre is doing is trying to identify that way earlier in the process. Being able to see if you can use something like a low-cost test, like an EKG, and be able to stratify and identify patients at high risk for structural disease. Because if we can identify disease, we can then be able to treat it and be able to have these patients go home healthy. And that's going to be the core, I think, of a lot of what we're going to see and do with AI. The same is true with postpartum depression. Mm-hmm. Dr. Jolly with Dr. Pathak and Zhang, all the three of them are really looking at developing predictive models that can assess whether or not changes in a patient's status can increase the risk of postpartum depression or mood disorders. Another great doctor, Zujin Park, is also using, using waveform data to be able to predict certain conditions in an ICU setting. She has an unbelievable demonstrated career. Dr. Sujin Park has done an unbelievable job over time and really has done and has an impressive career in studying these areas. And we now need to support her with the right teams, the right resources to be successful and to hopefully be able to predict and identify these conditions like things like stroke, and how do we then make that actionable for patients.
Mm-hmm. Mm-hmm. What else? I mean, obviously, the suite, as you mentioned, the technologies are here. Obviously, you're putting them to work. What else coming down the pipeline gets you excited in terms of these next generation tools? We've spoken to folks about things like digital twins, distributed clinical trials, diagnostics in the home. Where do you think this is all going? What is, Dr. Peter Fleischut sort of 10-year vision on where this potentially all ends up? Because it clearly, you're at the forefront of all it, but these new tools are coming out each and every day, and you have to evaluate them based on what you want to bring in house, what you want to potentially invest in, because I know you do some of that as well. But what else gets you excited? Where's it all headed?
Yeah, that's a great question. I think we'll see more and more in the home. We'll see more hospital at home. We'll see more care models being created. The thing that really excites me, I would say, is the advancements in two areas, which is the advancements in diagnostics and the advancements in therapeutics in terms of medical technology. I'll start with medical technology and therapeutics. I spend a significant amount of my time on how do we improve the overall process for people to get treatments. How do we have the right care models? How do we use the right technology? How do we help people get through the process so that they can get to the right doctor, get the right treatment, get the right education, have the right logistics to get that treatment to their home or have them come into like an infusion center? And as the treatments in the medical technology advance, this is going to get much more complicated. We've spent a lot of time in the space of specialty pharmacy. With cell and gene therapy, it's going to only get more complicated. As we embark on more and more precise therapies, we're going to have to embark on better data and better screening diagnostic tools. Mm-hmm. So take, for example, a condition like cardiac amyloidosis, the abnormal deposition of a protein in the heart. Yep. That is a condition that can be treated. There's many treatments out today, and there's many treatments coming down the pike. The challenge is how to screen people for it, how to identify that they have this condition. And when we identify them, let's get them through the process. And so I think there is extreme excitement around the ability to have really targeted diagnostics and targeted therapeutics to be able to treat people in ways that we've not been in the past 50 years. I know that I will spend probably the majority of my career on this because of how quick and how fast it's going. Just 2 months ago, we started with a new treatment for patients that have amyloid Alzheimer's that's causing them to have Alzheimer's at a young age. Yeah. And we were able to, how do you identify these patients and how do you treat the patients and get them onto a treatment that now exists that didn't before and get them into these trials. And I think that's extremely exciting how we use the data, identify the patients, and then treat them.
Peter, say, because, when I read your bio earlier, clearly you have broad responsibility over all these areas and strategic vision. And one of the things I mentioned at the end of that was you're also, in addition to all of this, responsible for the cyber security side of this. And clearly in what is, multiple campuses, multiple hospital centers and clinics and so forth, and the networks. This has become more and more of an issue, whether we're talking about healthcare or any of the other industries that we talk about. Say a few words, just if you would, about the importance of technology alongside with everything in the pharmacy, in the hospital, and the patient care system on the cyber security side of managing a system this large.
Sure. I mean, first and foremost, I have to say with all these areas, there's unbelievable great leaders on my team that run these areas. And those are the people that really make it happen. And that's true with our information security and our technology risk. Jennings Aske is our Chief Technology Risk Officer. and John Freischauer is our Chief Information Security Officer, and they both have done an unbelievable job in protecting our patients, protecting their data, and really bringing us to a very stellar program in terms of how we think and how we plan for the future. So I think it's core to all this. If we don't have good cybersecurity, we can't do anything that we've talked about on this call. And they have really done an unbelievable job. So it's really those people that have driven those programs, and the same with all the other things I mentioned.
Awesome. What else is coming up? I see that, obviously in addition to all these responsibilities, you do get out into the public sphere a lot, go to conferences. I saw that you were you gave a keynote at the Columbia Business School Digital Health Summit a few months ago. Anything else coming up for 2023 as we get into 2024 that we should know about in terms of places you're going to be speaking, conferences where we could listen to you, run into you possibly, and meet you? Anything else on the calendar that I did not highlight, please?
Yeah, I mean, there's always opportunities. I mean, the past 2 days, actually, I just spent 2 days ago, I was in New York City, and actually in a local conference where people from all over the country were attending. And it was a great opportunity to really, be out there and just listen to others and find out what are the other areas we're not investing in. What are some of the things we should be doing that we're not doing? And then yesterday, I actually flew to Chicago I was at a ideal event. It was a McKinsey Provider Council that was put together, and really sitting with a lot of my peers and like trying to learn from them and other industries. What are the things that we should be focusing on? What are some of those additional areas? So, I always am looking for opportunities to be able to learn from others and share so that, together we can really solve some of these challenges, because I do think we're in this together. And so, nothing on the schedule, as of right now that's fixed, but I do think that there's a lot of upcoming opportunities. And it's exciting to get back out there. COVID was a lot of Zooms, but it's really nice to see and interact with people in person again. And it's exciting because, there's a lot of opportunity for all of us out there.
Yeah, absolutely. Well, it's been an extremely impressive journey that you've been on. I look forward to continue to follow you, rooting you on. Obviously, going to be covering some other guests from NewYork-Presbyterian that you were just mentioning as we dive deeper into some of these tools. But really great stuff. Everybody that is going to be listening to this particular episode of our show across the various podcast networks or watching on the YouTube channel. Again, you've been listening to Dr. Peter Fleischut, Group Senior Vice President, Chief Information and Transformation Officer, NewYork-Presbyterian, doing really amazing things to spearhead these productive, patient-centric technologies in their organization, providing better quality care and better outcomes. Peter, I want to thank you again for taking the time out of your schedule to come talk to us for a little while about everything you're up to. Obviously, thanks for what you do for everybody in the system. And as we like to say on our show here, thanks for helping to create a better tomorrow for so many people via the work you're doing. Really great story.
Thank you. I want to thank you very much for the opportunity. And I also want to thank the people that aren't able to be on here. It's really the team that makes these things happen. And especially want to recognize Weill, Cornell, and Columbia and the providers there. They do an unbelievable job, and none of this would be possible if it wasn't for them.
Outstanding. Great having them.